So good morning, everybody.
Morning.
Happy New Year. I'm Althea Silver. I'm the nurse coordinator in the Movement Disorder Center here at Beth Israel. So without further ado, we're going to learn about how to get a good night's sleep. Dr. John Luggage is here. She's a neurologist in our center in the sleep department, and we're very happy to have her here Saturday morning. So thank you.
Yeah, it was fine. Good morning, everyone. So as she said, I'm a neurologist. I trained in sleep medicine. I do mostly research on sleep and memory. I've also studied Parkinson's disease a little bit. I have an interest and have moved also into memory and sleep apnea and memory and dementia. Those are my interests research-wise. But today we're going to talk about getting a good night's rest and about sleep disorders. So sleep is important. This is a survey looking at middle-aged people, and on the right side, older people, and sleep must be important. Otherwise, it's really hard to explain why we spend so much of our lives sleeping. And in the middle-aged group, there's also work that takes up a lot of time. But when you look on the right side, just here, it's really, if in the age 55 and up, it's really the majority of your day that you spend sleeping. And I just wanted to go over what a good night's sleep looks like. Up here we have wakefulness, and then right here the person is drifting into sleep, so there's sleep onset. And then here you can see deeper stages of sleep. So the beginning of the night is typically more rich in slow wave sleep. And then towards the end of the night, there's more and more REM sleep. And then most of the night is really spent in stage 2 sleep, which is an intermediate non-REM sleep. And we go through these cycles. So you go through light sleep, deep sleep, REM sleep, and then this repeats itself. So this is called the ultradian cycle. About every 90 minutes, we go through these cycles as we sleep. And this is all the different sleep stages are based on changes that we see in the EEG, in your brain waves. And this is awake EEG, so you have faster activity, then you have stage 2 sleep, and there are very specific features. So there is this wave here, it's called a K complex, which is something, when you're drifting in and out of light sleep and you're not quite aware of whether you're sleeping, or you might find your partner snoring and they pretend they say they haven't slept. It's often because they haven't really gotten any K complexes. Oftentimes, once you have a K complex, you're actually aware that you're sleeping. And then we have sleep spindles. They're also features of stage 2 sleep. They're associated with memory consolidation. Some people think with intelligence. Then there are deeper stages of sleep, stage 3 and 4. They have really these slow delta waves. And then there's REM sleep, which consists of this kind of mixed frequency. And a lot of times in the past, people thought this looks very much like a wake state. And that's why sometimes you find it being called paradoxical sleep, because the frequency looks very different from the other stages. And then we also use the eye movements to determine sleep stages. So as you're getting drowsy, you have those slow rolling eye movements. Then they're fairly quiet in stage 2 and 3. And then during REM sleep, as the name suggests, you have these rapid eye movements that go all the way. And we also use the chin tone to determine sleep stages. So during the wake, it's fairly high, and then as you go into deeper stages of sleep, it decreases, and then in REM sleep, it's really, really low. And this is all part of the normal sleep physiology. So why is sleep so important? Well, for one thing, brilliance is the result of a well-rested mind. So there are some contrary to belief that very gifted people don't need to sleep a lot. This is from New York Magazine about a year ago, that somebody actually took the time and looked at writers, composers, and how much sleep they got. And surprisingly, they got a good amount of sleep. They really went to bed earlier, probably because of the time and less electronic gadgets, but they did also get, on average, 6 to 8 hours of sleep. Some people even napped. So there's very few that really went by very little sleep. And
could you explain?
Is it too small?
Yeah.
You want to? I'm sorry. It's probably also okay. So here, I'm from Germany, from Lübeck. So here's Thomas Mann from my hometown. He's here, and then maybe it's easier if I do this. This is Beethoven, right here, and then you have Immanuel Kant, Victor Hugo, right here. Then
I have no idea what the lines meant. Now I know.
so this is the midnight. This is the time. This is the clock. So that's the time that they go to bed, and this is how long they sleep. And so Thomas Mann went to bed at 12 and slept until 8. And Gustave Flaubert, who wrote Madame Bovary, went to bed late, was a delayed sleeper, but also went to bed at 3 and slept until 10. And then here's Victor Hugo, went to bed at 10, got up at 6. Who else? Tchaikovsky went to bed at midnight, slept until, 8? And who else do we want to pick? Well, you get the point. It's really, they do get a good amount of sleep or rest. And the importance of sleep becomes very apparent when we look at the effects of sleep deprivation. So sleep is very important to our brain, to memory. Lack of sleep causes memory impairment, sleepiness, poor judgment, symptoms that are very similar to ADHD, more in children, to ADD in adults. It also affects our heart. It increases the risk for diabetes. It affects our immune system. It causes pain. When people are sleep deprived, they have aches and pains very similar to fibromyalgia. It also changes hormones. So there are certain hormones who control our hunger, so leptin and ghrelin, they change, and so there's an increase in appetite when we don't get sleep. So sleep really has a big impact on everything, really. And then more recently, there was a very exciting research that also showed that lack of sleep causes a buildup of toxins. And they were mainly focusing on amyloid, which accumulates in people with Alzheimer's disease in the brain. And so this went all over the news, and it had articles such as "Brain takes out the trash while we sleep," and you see the little people cleaning up the brain. This is all based on a science paper where they came up with something called the glymphatic clearance system. And this picture shows a fluorescent dye that has been injected in a mouse while it's alive. And it shows the red represents greater flow, and this mouse is asleep. And the green is less flow, and this mouse is the same mouse, actually. So the idea is that sleep promotes the removal of amyloid, which is a toxin in the brain, that at a faster rate than the wake state, and it's especially important to preserve metabolic homeostasis. And the hypothesis is that neurodegenerative disorders can be the result of a mismanagement of toxic molecules which accumulate in the brain. So now I'm going to talk about the sleep disturbances in Parkinson's disease. So even James Parkinson's disease, as you may know, in his famous essay on the shaking palsy, acknowledged that disturbed sleep is actually one of the features in Parkinson's disease. And sleep disturbances are some of the most striking non-motor symptoms of Parkinson's disease, and they affect a really large number of people, 74 to 98%. They often precede the onset of the motor symptoms of the disease by 5-10 years, sometimes even more. And they can also worsen mood disorders and cognitive problems. So why is Parkinson's disease so associated with sleep problems? And to answer that, we really have to look at where are the centers that generate sleep in the brain, and you'll see that the classic sleep centers in the brain are really located in areas that are also affected by Parkinson's disease. And I don't want to go too much into the details here, but there are many subcortical regions that are involved, so the thalamus and hypothalamus and the pons, so down here in the brainstem. Again, all areas that are affected in Parkinson's disease. And aside from the area, the anatomical areas that are affected, there are also, across the night, there are changes in our neurotransmitter states of the brain. So here is an example. In normal wake state, there's something called acetylcholine that is high, and norepinephrine. And then, just to give you an idea, quiet wake, they all tone down, and there's less of these transmitter states. Even less in slow wave sleep, and during REM sleep, they increase. And then dopamine is also very important, plays an important role in sleep regulation. And it's mostly known for regulating motor function, but it also seems to be important for the arousal system, and it helps regulate sleep-wake states. So there's a whole, again, here's the brainstem. There's something called orexin neurons, and they all affect here wakefulness. And then here you have the dopamine area that is also involved in this process. So now I'm going to give you an overview of the different sleep disorders that are very common in Parkinson's disease. So the most common one is insomnia. So I really like this one. No wonder you have insomnia, lying there awake all night. So it's the most common sleep disorder in Parkinson's disease. And what it mainly means, so insomnia generally is the difficulty falling asleep, staying asleep, or early morning awakenings. And in Parkinson's disease, it seems to be less the falling asleep as being a problem. It's mostly sleep fragmentation, so waking up often, and the early morning awakenings, then having a hard time once you've woken up going back to sleep. And the origins of the insomnia are very multifold. So they have to do with inadequate control of motor symptoms. So there's nocturnal dystonia and increased rigidity and stiffness. And for example, when you have a natural awakening and you feel very stiff and you have these motor symptoms, it's very hard to go back to sleep. There's also vivid dreaming that has been reported, and nocturia. So going up to the bathroom at night is a very common nocturnal feature of Parkinson's disease. And that has to do with impairment of the autonomic system, of the autonomic functions. So it's harder to control your bladder. And then end of dose urge incontinency. So once the medication wears off, there's also an urge to go and use the bathroom. And so that is also very fragmenting. You have to go up, you have to use the bathroom, and then you go back, and then you have all these maybe motor symptoms, and it's harder to go back to sleep. So possible treatment approaches are a lot of times a change in the formulation. So longer acting dopamine medication has been shown to help. You can also change the timing of the medication. So additional doses at bedtime, middle of the night doses. There's a study that shows if you take a medication in the middle of the night, it can help. We also have to be aware that some of the medication that you might be taking at certain times during the day are stimulating, are alerting, and you should be taking them earlier. Minimizing fluid intake in the evening can be helpful, and obviously taking diuretics earlier in the day. So the next disorder that I'd like to talk about is sleep apnea. And there are some controversial reports about whether that is more common in Parkinson's disease. So then some studies used to assume that there is some stiffening of the airway that makes you more prone to develop breathing problems, but that really hasn't been confirmed. But the reason I put it here anyways is because it is so common. It's a very common sleep disorder. It is more common as you get older. It affects up to 60% of older adults. And also there's so much evidence that untreated sleep apnea can also affect our memory, our mood, and everything. And so that's why I think it's still worth talking about it. So in obstructive sleep apnea, which is really the most common type of apnea, there's also essential sleep apnea where you don't have the drive to breathe, but that's very, very rare, and that's usually due to heart disease or severe bilateral strokes. The most common one is obstructive sleep apnea. And so on the left side, you can see a non-obstructive airway. And so this is a person lying on their back, and the air comes either through their nose or through their mouth, and it just goes down here and then into the lungs. So there's no blockage here. And then in somebody with obstructive sleep apnea, they have an obstructed airway, and so that can occur at various levels. So it can be the soft palate, which is the part where the uvula is. You can have a small airway naturally. The tongue can be large and fall back. There can be areas further down that are small. A lot of times it has to do with weight, and especially the weight around your neck. So we generally say in men, if your neck circumference is larger than 17 inches, you have a higher risk. In women, it's 15. There are also families with a small airway, and that's how in a lot of times that everybody in that family snores. They may not be overweight. That can also be the mechanism. And as I showed you earlier, the muscle tone goes down as we go to sleep. And during the day, people are fine. Their muscle tone is high and the airway is kept open. At night, when the muscles relax, the airway becomes more narrow. And so here is the cycle that you fall asleep. The airway muscles relax, becomes more narrow. You stop breathing, or there's no airflow. You want to breathe, there's just no airflow. The oxygen drops as a result, and then we have sensors in our vessels that will register that the oxygen is low, and they wake you up, and you do this grasping of air, and then you get the oxygen, you fall asleep again, and then it happens again. And it can happen many, many times throughout the night. Oftentimes, most of the time, the person that has the sleep apnea is not aware of having it. It's usually, I would say probably 80 or 90% of people with sleep apnea come to my clinic because their spouse or partner tells them they're snoring and gasping, and it's very rare that the person themselves say, I'm gasping for air, or has some breathing problem at night. And so this causes disrupted sleep. And this is how it looks when we do a sleep study. And so when people get wired, and here you can see the the sleep stages that I showed to you earlier. You can see that this person looks very much different than the other one that I showed you, and that it's very fragmented here. There's very little REM sleep because you need to be able to sleep soundly in order to really go through these cycles. And then here is the oxygen. So up here is 100%, here's 90%, and you can see that here are the obstructive events. And so with all of these, this person really dips down and has low oxygen. A lot of times they also have what we call arousals, which are not awakenings, but it's a little shift in your brain activity to almost an awake state. And that all these together, the low oxygen and the fragmentation, causes the effects of sleep apnea. And so the consequences of untreated sleep apnea are really, again, multifold. You can imagine when you wake up multiple times and gasp for air and you have low oxygen at night, your blood pressure goes up. And your blood pressure doesn't only go up at night, it also stays up during the day. So it increases the risk for high blood pressure. And that increases the risk for heart attacks and strokes. That's really, usually the mechanism by which untreated obstructive sleep apnea causes the higher risk for heart attacks and strokes. It causes memory loss, increased risk for diabetes, low mood, depression, insomnia, and early death is related to all the other risk factors. So it's certainly not good. The good news is that there's treatment available. Unfortunately, there's not a pill that you can take. It's a little bit more involved. And so many of you might be familiar with some of these. The gold standard treatment is still the CPAP. And it's a machine that puts compressed air in your airway, as in this example. So the machine puts and has a tube, and then you wear a mask, and it just keeps your airway open. So it doesn't give you oxygen, it's not breathing for you, it just keeps your airway open. And if you're able to tolerate that, that can make a huge difference. And in the past, these machines used to be very big and cumbersome, and now they've become much smaller. They're even female versions. But this is still the gold standard. So most people who have sleep apnea will try and get them used to the CPAP machine, because we know that if it works, it really makes a big difference. An alternative, if you have mild to moderate sleep apnea, are these oral appliances. So this is something that a dentist makes. And it's like a mouth guard, but it has metal parts on the side. And they pull the lower jaw forward and thereby create more space in the back of your throat. So that's an alternative. And typically, if you use that, you go through a few visits, and then we do another sleep study to make sure it's working. There's also a surgery, which usually means cutting. And I put it small because the success rate is 50%. So we really don't recommend that as a first line. And children with sleep apnea, they often have large tonsils and adenoids, and they have a 90% success rate if they go to the surgeon. So they all go to the surgeon as a first round. But in adults, it's much more complicated. So there are many more areas that can collapse, and you cannot really examine somebody and tell for sure where the area of obstruction is, because when they get examined by the throat doctor, you're usually awake, they put a camera down, and it's very hard to see where the obstruction really takes place. But this means usually this type of surgery is the most common one, UPPP, what they're doing is they're cutting out the soft palate and just create a bigger area for you to breathe. Again, some people are successful, but I would say the majority that I see are not. Then there are a couple of more alternative type treatments that I wanted to mention. This is called Provent. These are little strips that you can put over your nostrils, and they have a valve in here. So they create a little bit of an increased pressure when you wear them. Some people use them when they go camping, or if they don't want to drag the machine with them. And I've, again, had mixed results with these. Some people do fine, some people don't like something clogging up their nostrils. And then this is a fairly new machine. This works differently. This works more with suction. This is called the Wings device that came out maybe 2-3 years ago. It has a mouthpiece, and again, it works with suction, and it's more an alternative when you are not able to tolerate the CPAP. Right now, it's only covered in California. The medical insurance covers it only in a few states. I know California. you can buy it and try it. It's about $1,000. And then if you don't like it, they return it. At least, so that's a possibility. But I haven't had too much good luck with this machine, even though their data looks very good. So the benefit of CPAP, again, it basically reverses all the adverse effects. It reduces sleepiness, it improves memory, driving performance, very important, improves cardiovascular risk factors, the reduced risk for stroke and hypertension, improves pulmonary function, and reduces the risk for diabetes. And so many benefits. The next sleep disorder that I want to talk about is restless leg syndrome. And again, also some controversial reports, whether it's more common than in Parkinson's disease. Some studies suggest it's twice as common. But again, that's controversial. It is fairly common overall in the population. A lot of times people develop this after they have the motor symptoms of Parkinson's disease. The symptoms are subjective. So it's an irresistible urge to move the legs. People describe unpleasant sensations, burning, itching, crawling, feeling worms under the skin. It worsens in the evening, so it has this circadian element to it, and then it improves with movement. So what people often do is they have this sensation that comes on at night, especially oftentimes people don't notice it earlier in the evening, but once they're ready to go to bed, they notice it, and then they start to take showers or they walk around. And what it really does, it delays bedtime. And so naturally, the restless leg get better in the early morning hours. And a lot of times people say that's when they finally are able to rest. And so they have a very delayed sleep cycle. And the other one that often gets confused with this is called periodic limb movements of sleep. And that's very common generally in older people. It may coexist with restless legs, or it can be present in itself. It consists of involuntary periodic leg movements that people do at night. And it's present in about 30 to 80% of patients with Parkinson's disease, and it's again more common as the disease advances. So the periodic limb movements of sleep compared to restless legs, which is a subjective sensation, this is really visible. This is the movement of the legs and the stretching and flexing, and we can see that on the sleep study. So just to orient you, this is just a snapshot. This is the brain waves. This is the eye movements, and then here you have the breathing, and here you see the leg movements. And as you can see, they're very rhythmic and periodic. That's how they got their name. And they usually occur in 20 to 40 second intervals. They last 0.5 to 5 seconds. And they can mostly involve the lower limbs. It can be one leg, can be two legs, can also be the arms. Both restless leg and periodic limb movements have similar pathway. They also are influenced by dopamine. And things to avoid are very similar for both of them. That's why I lumped it together. So tobacco and caffeine make it worse. Antidepressants, in particular SSRIs, make them worse, and antihistamines. So Benadryl, a lot of times the sleep aids that you buy over the counter contain antihistamines, and they make it worse. And the treatment is with dopamine agents. So restless leg and periodic limb movements also happen in healthy people without Parkinson's disease. And usually the first line that we use is dopaminergic agents. So a lot of times Parkinson's patients are already on some of them. So that would mean adjusting the dosing. So increasing the evening dose, adding an additional dose late in the evening or middle of the night. There are other medications. I just listed them for completeness, but gabapentin or Neurontin is actually a really good medication for it. And then there's also a link with restless leg and periodic limb movements and low iron. And we usually get a ferritin level, which is representing your iron stores, and if that's low for various reasons, then iron supplementation can also be helpful. So the next section I want to talk about parasomnias, which are the unusual behaviors in sleep. And this is the classification. So unusual behaviors can occur out of non-REM sleep and out of REM sleep. The non-REM parasomnias are sleepwalking, sleep terrors, bruxism, confusional arousals. I'm not going to focus so much on those. I will be focusing on the REM parasomnias just because they are more frequent. And that's REM sleep behavior disorder, sleep paralysis, and nightmare disorder. So here, you have that also, is an example of Mike Birbiglia is a comedian who actually had a show called Sleepwalk with Me, in which he talks about his experience with REM sleep behavior disorder. And so I just wanted to read that to you because I think it really sums it up very nicely. In my apartment in Brooklyn, I had experienced a series of frightening sleepwalking episodes, but I just didn't think they were serious. I would stand on my bed and try to fight flying jackals, and I had fallen in the living room, which in my dream was an Olympic podium. Still, I thought I was too doctor. On one trip to Washington State, I was performing at 5 colleges in 4 days. I was staying up late, obsessed with cable news coverage of the war, and eating pizza on my bed while on the internet right before I went to sleep. That night, I nearly died when I jumped through my hotel window in my sleep. That's when I saw a sleep specialist and was diagnosed with REM behavior disorder. For the most part, I've been able to control these episodes with medication and behavioral changes. I definitely have a lot more respect for the importance of proper sleep. So a lot of times, these behaviors actually persist and people just brush them off and really don't do much about it. And we actually saw a lot of, this was an episode also on This American Life on NPR, and we actually saw a lot of people come into the clinic because they didn't even know that it was something that could be treated. A lot of people, including, I think he mentioned that also, end up sleeping in a sleeping bag with mittens and do all sorts of things to really trying to keep it together and keep themselves safe. So REM behavior disorder is the next focus. And it's consisting of vigorous and injurious behaviors during REM sleep. So the behaviors include limb and body jerking, punching, kicking, talking, shouting, swearing, leaping from bed, running into walls or furniture, and striking and choking the bed partner. So various, I think what is very, compared to sleepwalking, these movements are very violent. And they occur out of REM sleep. And again, normally, as I showed you earlier, the muscle tone during REM sleep is really, really low. And for a variety of reasons, and I'll explain some of them to you, this doesn't occur in REM sleep behavior disorder, and you have the normal muscle tone. And a lot of times, people really act out what they're dreaming. So it can be a lot of dreams naturally are about fighting. Sometimes it's playing soccer. People dive for the ball, and they just have these very violent movements. And unfortunately, some of them only come into the clinic after they had a serious injury that leads to them going to the emergency room. people are usually able to recall and describe their dreams. And they're often, again, typically dreams in which they're pursued, they're trying to fight back. Ironically, a lot of times they're trying to protect their bed partner, but they actually end up punching them. And upon awakening, sometimes there's a sense of fear, but usually they don't linger during the day for most people. Again, there are injuries to themselves or to their bed partners. And very importantly, violence is usually not concorded with the patient's character. So it's not that they usually have some unresolved issue or, mean people in real life. The prevalence in the general population is 0.5%. In Parkinson's patient, it's 15 to 60%. So it's very, very common. It often precedes the motor symptoms. So oftentimes it's about 5-10 years, sometimes even more, that people experience these behaviors, and then the motor symptoms come later. And I explain a little bit why that is. On this picture, it's quite complicated because actually the control of muscle tone during REM sleep is very complicated and complex. So here's the brain and here's the brain stem, and the control of muscle tone during REM sleep really is, the control center is here in the brain stem. And so there are multiple steps that are involved in toning down and inhibition that finally leads to the motor neurons and your muscles relaxing during the stage of sleep. And then you have the REM-associated atonia. So I'll have better pictures coming up, but this is very small. So here are the eyes, this is the EEG, and then you have, this is a very flat EMG tone. And then compared to REM behavior disorder, where there's just something not functioning properly in the brainstem, and as a result, the muscle tone stays up. And when the muscle tone stays up, you're more likely to act out these behaviors. And so here's an example, again, more visible. This is the eyes. This is the brain waves, and then here you see the EMG tone. And normally it's supposed to be flat, like here, and you see all these twitches, so there's a really high tone here in the chin and in the arms, as well as the legs, so it's everywhere. And then same here, you can see this even from the back. A lot of muscle tone during REM sleep. Here you can see even here better, the eye movements, the rapid eye movements that we see during REM sleep. This is, I think, dying. Yeah, it's very small. And the increased chin tone. There's also a reversible REM behavior disorder, and that has to do, occurs when people withdraw from alcohol, benzodiazepines, and barbiturates. A lot of antidepressants will also increase the muscle tone, so tricyclic antidepressants, SSRIs, we often see those causing increased muscle tone and causing the REM behavior disorder. So when somebody comes into the clinic, we always take a careful history of their medication and see if something can be altered. And it's not all related to their disease. It might just as well be the medication, which is often easier to change. The treatment is environmental safety, so making sure there are no sharp edges in your bedroom. There's a medication called clonazepam, which is a benzodiazepine that we use at a very low dose, 0.5 to 1 milligram, and it can just prevent you from waking up and changing the muscle tone. And then melatonin, interestingly, which is a supplement that you can buy over the counter, has been shown to be very effective. And it's nice because it doesn't have the cognitive side effects that we worry about with clonazepam. So we really like to give it in people who have a neurodegenerative disorder or memory problems. You have to take it at higher doses though. So most of the formulation that you buy or you get at the drugstore are 3 or 5 milligrams, and you can easily go up to 12 or 15 milligrams with the melatonin. And, but in order to really make the diagnosis, you really need to come into the sleep lab and get evaluated. Sometimes, again, there are reversible causes, there are iatrogenic, disease-related, but sometimes it also occurs as a result of untreated sleep apnea. If you have another sleep fragmenting disorder, and then you can treat that primarily, and then the behavior will also improve. So it really is worthwhile seeing a sleep specialist to get help with that. So most people are fascinated by dreams. And this is Christoph Niemann is a graphic designer who did a lot of covers for the New Yorker. He also did a blog called Good Night and Tough Luck, and he describes very nicely different types of dream, and it's funny how strangely similar our dreams really are. I think most of us will have experienced some or all of these situations. And so this leads over to nightmares, which are fairly common in Parkinson's disease. And basically, it's a dream which causes a strong, unpleasant emotional response from the sleeper. It's usually fear, horror, pain, falling down, drowning, death. Death is actually very rare and somewhat concerning if that occurs. The individual is able to relate the dream content. And so that's very dissimilar from night terrors, in which somebody wakes up screaming, and they usually don't remember the dream content that well. They usually have a sense of fear. Nightmares occur out of REM sleep. Night terrors occur out of slow wave sleep or non-REM sleep. And the night terrors occur earlier in the night. They're mostly seen in children, but also adults can have them. But nightmares mostly in the second half of the night, out of REM sleep, and usually there is the individual remembers a very detailed dream content. They are very common. Nightmares are very common also in children, 20 to 40%, but the prevalence in adults is actually 8 to 30% have 1 or more nightmares per month. So it's not that uncommon, and it's more common in Parkinson's disease. The causes are multifold. Again, stress, traumatic events, high fever, withdrawal from REM suppressing medication, which then results in more REM sleep, can bring those out. And then there are some medications, particular beta blockers and some dopaminergic agonists who can also bring out the nightmares. Most nightmare sufferers are without any psychiatric history, though. The treatment is, if it's really stress, anxiety related, is so cognitive behavioral therapy, particularly for sleep problems. Minimizing the drugs that may precipitate those nightmares, so reducing anticholinergic, amantadine, selegiline, antidepressants, the dopaminergic medications. It's all a fine balance. And then instituting a regular sleep-wake pattern. And that's actually true for the nightmares and the REM sleep behavior disorder. For all these parasomnias, they tend to occur more when we have a varying sleep schedule. So if you sleep very little one night and then you try to make up, you tend to have more REM sleep or slow wave sleep, and that's what brings out these behaviors more. Sometimes, in some instances, all you need to do is really get that person on a very regular sleep schedule, and that can eliminate some or all of it. There's also, if the nightmares are really bad, there's also pharmacotherapy, but we don't usually give that very often. So prazosin, for example, is a blood pressure medication that reduces the the anxiety reflex, and that's been very helpful, but it reduces the blood pressure, which is a whole other problem in Parkinson's disease. So now I want to move over to excessive daytime sleepiness, which is, I focused on the sleep disorder, but a lot of times people come into the clinic not because really they're because of the sleep problems, but because of how they feel during the day. That the fact that they feel sleepy brings them to the clinic. So excessive daytime sleepiness affects almost half of Parkinson's patients. It increases as the disease progresses, and it hasn't really gotten a lot of medical attention until people noticed these sleep attacks that occurred with dopamine medication. And again, the etiology is multifactorial, and you have to forgive me. This is from a paper that was recently published, a review paper in Neurology, just to give you an idea of, again, all the causes that contribute to daytime sleepiness. A lot of it is, let's see if I can make it worse. The motor symptoms, depression, dementia, but here, almost all of it down here is the sleep problems. So it really is, it's not just the medication. People try to attribute it either to medication or to getting older. And one message that I also want to relay here is that getting older doesn't mean you have to get sleepier. In fact, there are many studies that suggest that as we get older, the sleep is more fragmented, we sleep less, but as a result, we don't feel sleepier. And so there have been studies where they sleep deprived younger patients and older patients, and then they had them actually do tests of reaction time and memory, and the older people did better. So it really is, again, getting older doesn't mean you have to get sleepier. So it really is worthwhile, if you feel sleepy, looking into whether there is a sleep disorder that can be addressed. And the treatment, this is almost not visible, is, again, it depends on the underlying cause. I just summarized it on the right side. So it's challenging. We usually start with good sleep hygiene. So having a good sleep schedule, regular sleep schedule, turning off your electronic devices before you go to bed. A lot of times the TV, phones, computer, they emit this blue light that is very stimulating. Even if you watch a very boring show, the light is still there and it tells your brain it's still bright and just keep going. So it makes it hard for people to go to bed. It's important to have a comfortable bed. Eliminate noises. Animals should ideally not sleep in the bedroom. They usually disrupt sleep. And then those are all good sleep hygiene that you can probably most people already practice. But then focusing on the underlying sleep disorder is important, and treating that, and then a detailed review of the medication regimen. And then patients who experience the sudden onset of sleep or sleep attacks should really be advised not to drive until the issue is resolved, because there have been a lot of accidents. So in conclusion, sleep disturbances in Parkinson's are common, are typically under-recognized and ineffectively treated. Parkinson's medication may be partly responsible for the daytime sleepiness, but there are many additional potential sleep disturbances. So again, coming back to Christopher Niemann, getting a good night's sleep is actually a lot more complicated than one would think. But on the positive side is that most sleep disturbances are treatable and addressable. And effective management of sleep disturbances and excessive daytime sleepiness can greatly improve the quality of life. And then finally, I want to conclude this talk about how much sleep do we really need. So we focused mainly on sleep quality, and I just want to conclude with the quantity. People seem to be obsessed with 8 hours of sleep, and that seems to be right where most of us should be. The National Sleep Foundation came up with recommended sleep times last year. They adjusted them, and they actually, in the past, they would just lump adults all together, and now they have older adults. And so most adults need about, I'm sorry, this is very small, 7 to 9 hours of sleep. As you get older, as I mentioned, you may sleep less, still probably needing 7 to 8 hours of sleep. But that's sort of the recommended sleep time. And you can also use how you feel as a, provided that you don't have another sleep disorder. If you feel refreshed with 6.5 hours of sleep, there's really nothing wrong with you. It's not that we have to achieve the 8 hours of sleep. Thank you.